Hi, everyone. In this video, we are going to discuss the structure of arteries, of veins, of blood capillaries, and capillary exchange, and many other items that are remaining on the slides as much as time allows. Starting by the arteries, as you know, the arteries are muscular vessels because their walls contain smooth muscle fibers. And you also know that the main function of the artery is to carry blood from the heart to the organ. Of course, we did not specify the nature of blood because you know that the majority of the arteries carry oxygenated blood that is rich in oxygen and poor in carbon dioxide. But there is an exception, one exception in adult persons, which is the pulmonary artery that carries deoxygenated blood. The wall of the artery is made of 3 layers, and each layer is called a tunica. So we have the innermost layer that's called tunica intima. This layer I'm showing on the slide, and it is called tunica intima because it is the innermost and it is in direct contact or intimate contact with the blood here. Because this is the wall, as you can see, we have cut out a wedge-shaped structure or a wedge-shaped part of the wall of the artery, and the tunica intima is in direct contact with the lumen of the artery that contains blood. This tunica intima is made of endothelial cells, one layer of endothelial cells, so we can call it inner endothelium. We can call it inner endothelium. And then we have an outer connective tissue layer, this one, which is also called tunica adventitia. So tunica adventitia is the outermost layer that is made of connective tissue. Whereas in the middle, of course, we will have a tunica media, which is the intermediate layer in between, and it is the tunica media that contains the smooth muscle layer. It is the middle smooth muscular layer. If we look at the inner endothelium or the tunica intima and the outer connective tissue, which is the tunica adventitia, we will find that they are full of elastic fibers that are important, as we said before. They are important for elastic recoil or returning of the artery to the original size after having been expanded. So inside the tunica intima, we have an elastic lamina. Lamina means a very thin layer. And since it is an elastic lamina, so it is a very thin layer made of elastic fibers. Moreover, in the outermost layer or in the tunica adventitia, we will have an external elastic lamina. So arteries are rich in elastic fibers. So if I ever ask you about the elasticity of the arteries, why, for example, arteries are more elastic or have more elastic walls than veins, this is because the arteries or the arterial wall is more rich in elastic fibers than the venous wall. The artery you see at the top of the picture, together with the wedge-shaped section, that is what we see under the light microscope, under the high power of the light microscope, are normal structures. But if you look at the bottom, you will see changes that occurred in the artery. And these changes are pathological changes, meaning that they are abnormal changes or they are indicative of diseases. Here, for example, we have seen the deposition of yellow flakes like a fish outer surface. You can see scales on the outer surface of a fish. Those lipid plaques or fat plaques deposit on the inner wall of the artery just in the form of small plaques that look like scales. So it's not a smooth inner lining that will result from this deposition of fat, but it is a rough inner lining, just like the outer surface of the body of a fish when it still carries its scales. The deposition of fat, therefore, resulted in two harmful effects. The first harmful effect is that it made the inner lining of the artery rough, and this results in clotting of blood, because blood is used to passing through an inner smooth endothelial wall. It's not rough, and it does not elicit clotting in the blood. It does not break down the platelets and make them release chemicals that induce clotting in the blood. But when the inner lining of the arteries or the arterioles becomes rough due to deposition of those yellowish flakes of fat, then there is roughness of the inner wall and more liability to blood clotting. Blood clotting means that the blood will be converted from its fluid state into a semi-solid state. And this, of course, might occlude the passage of blood to the cells and might result in death of the cells and tissues. The other inconvenience of such fat, these plaques or fat deposits on the inner wall of the artery is that they cause narrowing of the inner wall of the arteries, and therefore they diminish the blood supply to the tissue. These deposits inside the wall of the artery are called atheromatous plaque. So, or plaques. So the atheroma is this structure. This structure, this swelling under the endothelium, as you can see, and that swelling under the endothelium results from the deposition of atheromatous plaques. So finally, the resultant of all this is an upward swelling that further narrows the vessel, that is rough, that results in degeneration of the endothelial cells to the extent that we might have ulceration or discontinuity in the endothelium. And on top of this, because of the roughness, we can find a clot with all the resultant ischemia or diminution of blood flow that can occur to the tissues. Now, we are going to talk now about the elastic properties of the arteries. As you know, arterial walls are stronger than venous walls because arterial walls are thicker. So venous walls have almost the same structure. They have a tunica intima, they have a tunica media, they have a tunica adventitia, but the muscular wall or the muscular layer of the veins is much thinner. So the wall of the vein is much thinner than the wall of the artery, and the wall of the artery is stronger than the wall of the vein. So the wall of the arteries, when we say strong, we mean that it is stronger than that of the vein because of a more developed or a thicker muscular layer. And it's also more elastic because, as we said before, the tunica intima and the tunica adventitia of the artery have more elastic fibers than those of the vein. So we have now seen two important differences, anatomical or histological differences between the artery and the vein. Now, how is this elastic property or this elasticity important to the arteries? It is important during systole and it is important during diastole. It is important because when the ventricles contract, this elasticity allows the arteries to stretch out easily in order to be able to accommodate this extra amount of pressurized blood or extra volume of pressurized blood that's being sent via the heart. If they weren't elastic, they wouldn't be able to expand in order to accommodate the newly coming volume of blood. So this paragraph shows their importance during ventricular systole, the importance of elasticity. But elasticity is also important during diastole because it allows the arteries to recoil. What is recoil? It is to return to their original state. When would they recoil? They would recoil when the ventricles relax and when they stop sending blood to the arteries, when the volume of blood coming from the ventricles diminishes, and therefore the volume of blood in the arteries diminishes. They are no more expanded by the pressure of blood, so they need to return to their original size. Is this important? Yes, because if they don't return to their original size and they remain expanded with a very small volume of blood, this would result in a drop in the blood pressure. Why? Because the blood pressure results from pressure of the blood on the wall of the artery, by the force of the blood on the wall of the artery. So, and pressure is force divided by area. So you have a smaller force because there is no more blood coming from the ventricles, and meanwhile you have a large internal surface area of the artery because it is still expanded. So the numerator has diminished and the denominator has increased, and therefore the pressure drops a lot. But by returning to their original size, they keep the blood pressure considerably high and within normal. And now we have two definitions that are related to what we have just said. We have said that we have the elastic fibers are important during systole and important during diastole. So we have systolic pressure and diastolic pressure. What is systolic pressure? Systolic pressure is the maximum blood pressure in the aorta during left ventricular systole. Does it make sense? Yes. Why do we say during systole? Because it is during systole and during contraction of the ventricles that blood is pressurized to pass into the aorta, and therefore we can obtain the maximum volume of blood and therefore the maximum pressure in the aorta. Why are we specifying in the definition that it is the left ventricle? Because, of course, as you know, the thickness of the muscles of the left ventricle is greater than that of the right, and therefore the pressure generated on the left side by contraction of the left ventricle will be higher than the pressure generated on the right side by the right ventricle. But the ventricles do not remain contracting forever. They will relax, and when they relax, they stop ejecting blood into the corresponding large arteries. So the left ventricle no more pumps blood into the aorta, and the right ventricle no more pumps blood into the pulmonary artery. So the pressure in these large vessels during diastole will definitely diminish because the ventricles are no more sending blood, and the blood that was contained in the arteries have circulated farther away to the tissues. So we have another value or quantity, which is the diastolic pressure, and the diastolic pressure is the minimum pressure in the large arteries, or mainly in the aorta, because we specify the left side during left ventricular diastole. The normal value of the systolic pressure is 120, and the normal value of the diastolic pressure is 80 millimeters mercury, and the unit is millimeter mercury. And therefore, we can define the blood pressure of an individual by a systolic blood pressure and a diastolic blood pressure. So for example, when you measure the blood pressure of the patient, you will say that the pressure is 120 over 80. So what is the blood pressure? As we said before, when the ventricles pump blood into the aorta or into the pulmonary artery, this blood is sent under high pressure. And this blood, upon reaching the inner wall of the arteries, will exert a force on the wall of the artery. So the force per unit area, or the force that this ejected or pumped blood, this pumped pressurized blood will exert on the wall of the blood vessel per unit area. Of course, we should add here per unit area because pressure is not force. Force is pressure over area divided by area, or force per unit area, F over A. So in order for this definition to be more accurate, then we would say that the blood pressure in general is the force that the pumped blood exerts on a unit area of the walls of the blood vessel, or it is the force that the blood exerts on the walls, on the inner walls, of course, of a blood vessel per unit area. Of course, the blood pressure is always measured near the heart because it is, if you want to use a tool or a device, as we will see later on, to measure the blood pressure, then it will be in a site that is very close to the heart, because the pressure in the artery, for example, in the aorta, the pressure in the aorta is highest at the point where it originates from the heart. What about farther points, points that are farther away from the left ventricle? The pressure will diminish gradually because blood is being delivered to the tissues. So the volume of blood inside the aorta will gradually diminish as it circulates away from the left ventricle, and therefore the pressure will diminish. So the pressure is always highest near the arteries, in the area or the segment of the artery where it is closest to the heart. Of course, we cannot measure the blood pressure. We cannot measure the blood pressure in the aorta itself. I mean clinically in the clinic, but we can measure it in an artery that is called the brachial artery. Why exactly the brachial artery? Because the brachial artery is one of the branches of a vessel that arises from the aorta very close to the heart. And we usually measure the blood pressure in the brachial artery on the left side of the body, or in the left arm, because the brachial artery lies in the upper part of the, or in the left arm in general, in the upper part above the elbow. So this is where we are going to measure the blood pressure. Of course, we will have a whole lab, practical lab in the classroom about measurement of the blood pressure using a sphygmomanometer, the device that contains mercury and that is used to measure the blood pressure. But the details of the explanation and the theory behind will not be mentioned now in the video, because it would be much easier to discuss them in the classroom or in the lab. Now, there is another important definition, which is the pulse pressure. Since we have a systolic blood pressure that is normally around 120 millimeters mercury, and a diastolic pressure that is normally around 80 millimeters mercury, then there is a difference between the two. Is this difference important? Yes, it is this difference that makes you feel the radial pulse here. If the blood was circulating during the whole cardiac cycle, systole and diastole, at the same pressure, you wouldn't feel those thrusting impulses that help you determine the pulse and therefore help you determine the heart rate of the patient. So one of the benefits of this difference is that it makes you feel the pulse and therefore know the rate and therefore learn important data about the heart and the circulatory system of the patient. Because sometimes, other than detecting the pulse and knowing whether the rate is normal or not, so this is the first benefit, you can learn from the pulse pressure. You feel the pulse. This is the first importance. Number two, you can calculate or measure, actually not calculate, you can measure the pulse rate by counting those thrusting impulses at the wrist here at the radial artery. And I'll be teaching that you in class how to measure the pulse. And I think we did it with auscultation, but we're going to repeat it. And the third important thing you can learn here from the pulse pressure is how strong the pulse is. And this necessitates a certain amount of experience. You have to feel several normal pulses in order to feel a weaker pulse or to detect a stronger pulse. If you don't know what the normal pulse is, the amplitude of the normal pulse is, if you don't know this feeling, you cannot decide whether there is a full, strong, bounding pulse, or is it a weak, thready pulse that can be that can be detected with difficulty. Does this have a clinical significance? Of course, but these are too many details that would not be discussed here. So the pulse pressure, we said before that because of the elasticity of the arteries expand and recoil, expand and recoil. And this is responsible for pulse pressure. So the pulse pressure results from the systolic expansion and the diastolic recoil of the arteries. And the value of the pulse pressure is nothing but systolic pressure minus diastolic pressure. Normally, the numerical value of the systolic pressure is 120 millimeters mercury, and the normal value of the diastolic pressure is 80 millimeters mercury, and therefore the pulse pressure is around 40 millimeters mercury normally. So upon measuring the blood pressure to the patient, you can even not only roughly detect the strength of the pulse, is it strong and bounding or is it weak and thready, but you can also calculate the exact numerical value of the pulse pressure by subtracting the diastolic pressure from the systolic pressure. Here we have only one example for each of the two cases. If you have hypovolemia, if the patient has bled for a long period of time and lost too much blood, then the volume of blood inside the circulatory system will diminish and the pulse pressure will decrease. On the other hand, in case of aortic regurg, maybe we will have time one day to explain why in aortic regurg the pulse pressure increases. I can say it very rapidly. The pulse pressure increases in aortic regurg because during diastole, there is regurgitation of some of the blood from the aorta. This shouldn't occur, of course, and therefore this increases the blood that is present in the cavity of the ventricle before recontracting. So upon contracting upon contracting newly and the next systole, you will have a larger volume. A larger volume during contraction means a higher systolic pressure. So during diastole, the aorta loses blood that regurgitates into the ventricle, and this diminishes its diastolic pressure. And during systole, the ventricle will pump a larger volume of blood, resulting in a greater systolic pressure. So if the systolic pressure rises and the diastolic pressure in the denominator diminishes, then the difference definitely rises. The pulse pressure in, I'll tell you something that's clinically important. The pulse pressure in case of aortic incompetence is so increased, so much increased in severe cases of aortic incompetence, so that if the patient lies on the bed to be examined, you feel that the whole body of the patient is pulsating. The pulsations are visible everywhere in the neck. They are visible at the apex. You even feel that the head is nodding. The device that we use for measuring the blood pressure is called the sphygmomanometer. Here you have several types of sphygmomanometers. So you have a digital apparatus, and that digital apparatus is the less accurate because it needs recalibration every now and then. It needs readjustment with the mercury sphygmomanometer every now and then, because it is the mercury sphygmomanometer that is the most accurate. You have another one that is not digital, but that does not contain mercury, like this one, and that is called the aneroid sphygmomanometer. And then you have the traditional classic sphygmomanometer, of course, which is the older one, which is the classic one, and or the classical one, and it is the one that is more accurate. Of course, here you do not use your stethoscope. In the aneroid, you don't use your stethoscope neither, but in case of the mercury sphygmomanometer, you use the sphygmomanometer, as you can see here, as well as your stethoscope. Of course, I'll be getting my device on the first day we meet after the winter break, and we will be discussing all this in detail. So the most accurate sphygmomanometer is the mercury sphygmomanometer, and it's so called because it contains a column of mercury that indicates the blood pressure. And this mercury, as you can see here, for example, during diastole, it's stopping at 80, or the last sound we hear is at 80. So you can visualize mercury inside the mercury column, and you can detect that the diastolic pressure is 80. Of course, I'll be explaining this in detail. At the bottom, there is a reservoir for mercury, and after having finished your work, after having finished a measurement of the blood pressure, you have to close this reservoir. Otherwise, you might find that some air bubbles can pass from the cuff or from the cuff into the mercury. And if there are air bubbles, this will totally interfere with the elevation of mercury inside the mercury column and will damage the apparatus. Of course, as you can see, the rest is made of rubber tubes, and you have here a cuff, and that cuff rotates around the arm of the patient, and it is inflatable. Therefore, you can increase the air pressure inside, and it is made of rubber. This is the brachial artery I'm talking about, and the brachial artery arises from one of the major branches of the aorta, and therefore the brachial artery is the closest to the closest accessible artery. Of course, there are closer arteries, but the brachial artery, why did we select it to measure the blood pressure from? Because the brachial artery is the closest accessible artery, the one that we can palpate, the one whose location can be easily detected. And as we said before, the brachial artery lies in the upper arm. We select the left brachial artery because it's closer to the heart than the right brachial artery. All these precautions are taken, I mean, being close to the heart and the left side, in order to make the pressure we are measuring here the most representative of the pressure in the aorta. It would be inappropriate, for example, to measure the pressure in the radial artery because this radial artery that lies in the forearm is farther from the heart. Therefore, the pressure would gradually diminish as the blood passes towards the hand, and therefore the pressure in the radial artery would be lower than the effective pressure inside the aorta. What we want to measure is the blood pressure inside the aorta. We rotate the cuff of the patient around, the cuff around the arm of the patient, and there is something that sticks. The two layers can stick to each other to fix the rotation or to fix the cuff at the diameter you want. It should be just above the elbow here, or what the elbow from this side is called the cubital fossa. And this cubital, cubital, fossa, fossa, this is where we are going to palpate the brachial artery. So we are going to use your index and middle fingers, just to use them to detect the radial pulse. And once you feel the pulse, you will put your stethoscope here, because this would be the exposed part here of the brachial artery. Usually it is medial to the biceps muscle. If this is the biceps muscle, then medial to it, towards the body, you will have like a groove, a depressed a longitudinal groove, where you can find the pulse of the brachial artery. And as we said several times before, you cannot feel the pulse unless you push the artery slightly against the bone. And the bone here is the humerus bone, but don't press too much to feel the artery, because if you press too much, you would occlude the artery and you wouldn't feel anything. And then what are we going to do? We are going to inflate here using this inflatable piece. We are going first to open the valve. Of course, we open the mercury reservoir first, and I'll tell you how in class. And then we open the air valve to allow the passage of air. And then we will start squeezing this part in order to inflate the cuff. Meanwhile, while we are inflating the cuff, we put the earpieces of the stethoscope well fitting in our external auditory canal. And as we inflate, we start at a certain point hearing the heartbeats. So you hear the heartbeats, you hear the heartbeats, you hear the heartbeats, and you continue inflating until there comes a time when you no more feel the heartbeats. When you no more feel the heartbeats, you raise again a further 10 millimeter mercury to make sure that you don't miss anything, because sometimes you find a gap and then you hear another sound. So in order to avoid this auscultatory gap, you like pump air, and then the mercury rises, and you hear the heartbeats. And then, for example, at 200, you no more feel the heartbeats. So you don't stop all of a sudden. You continue, for example, until 220 to avoid this gap. Maybe it stops, you no more hear the beats, but after 20, you can again hear them. Once this occurred, you start, of course, the patient feels very uncomfortable during this inflation procedure, because the inflation you are applying here makes the pressure very high and the patient feels severe pain. So when you reach the maximum, which is the 10 millimeter mercury, after no more sounds are heard, you start deflating from here. You start moving the valve in the opposite direction. So the cuff starts to deflate, to empty from air, to unload from air. The patient feels more comfortable because no more pressure is applied. Blood starts to flow normally in the forearm, and mercury starts to descend downward until, again, you no more hear any sound. If you no more hear any sound at 80, then 80 is the diastolic pressure. So you start inflating until you hear no more sound, for example, at 200, then 200 is the systolic pressure. You start deflating until you no more hear sound at 80, then 80 is the diastolic pressure. What is the explanation for this? The explanation for this is that when you start the procedure, when mercury is still here, for example, at 40, the pressure applied to the artery here is almost negligible, so the artery is fully open. And when the artery is fully open, the blood flow is smooth, so you no more hear, you don't hear any sound because there is no turbulence. And then you start inflating until you reach 80. The mercury rises to 80. You start to hear sounds, but while you are arising, while mercury is ascending up, you don't stop, you continue. But you take into consideration that you started hearing sounds here. So this will be most probably the diastolic pressure when you are going to descend downward. Why here above 80, we start hearing the heart beats or the heart sounds? Because the artery is partly occluded. It's not fully open. So at the beginning, it was fully open. The flow was smooth. We don't hear any sound. As we raise the pressure above 80, for example, at 100, I start hearing sounds. Those sounds are due to flow of blood in the artery, but this time the flow is turbulent. So they are not really heart sounds, but they are sounds due to flow of the artery in the of the blood in the brachial artery, and that flow is a turbulent blood flow because the artery is not fully open, it's partially closed. Why is it partially closed? Because you are compressing it from outside. As you go further upward and reach, for example, 200, you no more hear sounds afterwards as you ascend. Why? Because at 200, the artery is fully occluded. When the artery is fully occluded, no blood passes at all, so no sounds are heard at all. And this is most probably the systolic pressure, because the pressure you applied from outside, that is measured here or denoted here as 200, was capable of completely occluding the artery. So it is equal to the inside pressure, and it is most probably the systolic pressure. As you descend downwards, the same procedure occurs. When you reach, for example, 100, partially closed, so turbulent flow. But when you reach below 80, you hear no more sounds because the blood again becomes smooth because the pressure has been relieved. I know it's not easy to realize, and it would be more understandable when you see it in the classroom using the device itself. But we are going to read the slide, the text together. Maybe upon reading the text, we can understand it more. So we have blood pressure measurement. We inflate the cuff around the person's arm above the expected systolic pressure. For example, if you are expecting your patient to have a blood pressure of 200, which is very high blood pressure, but you already know that your patient has an uncontrollable, for example, blood pressure, so you will raise it above 200. But if you don't know the patient, you will raise it, for example, above the normal value by 40 or 60 millimeters mercury. So you are going to raise it, for example, until you reach 160, which is 40 millimeter mercury above normal, which is 120. What happens if I raise it above 160 to make sure I am above the systolic pressure, I am above the expected systolic pressure, and at which I will expect the vessels to be completely closed, and I'm expecting to hear no sounds, and I still hear sounds of blood flow. So if I still hear sounds of blood flow, this means that I have to raise again and again, because this means that the blood pressure of the patient is not 160, but it is above 160. So you raise the pressure above the expected systolic pressure to temporarily close the blood flow in the brachial artery. When you close the blood flow in the brachial artery, you hear no sound at all. And then the cuff is connected to a gauge containing a column of mercury, as I explained, that rises as the pressure in the cuff increases. And then after having done this, you start descending down. How would you descend? How would you make the mercury descend? By deflating, by releasing the air in the cuff very slowly, not once at a time. If you deflate the cuff once at a time, you would skip the level of 80 millimeter mercury or 70 or 60, which is the level of the diastolic pressure of the patient. And you will still listen the sounds of turbulent blood flow, and you have to watch the mercury column. And by the way, as you hear the sounds while the mercury descends, you can also feel that the upper border of your mercury column is pulsating. So experienced doctors can, even without, even in a noisy room, detect that there is still blood flow in the artery, turbulent blood flow, because of the pulsations of the upper border of the mercury column. So as you are deflating, as we said before, the uppermost value is the systolic pressure and the lowermost value is the diastolic pressure. Under 80 millimeters mercury, as I said, the sounds will disappear because the blood vessel is fully open and there is smooth blood flow. So to summarize, when we have a fully open artery, we have a steady blood flow, no sound is heard. Like, for example, below 80 millimeter mercury. When we have a fully closed artery, like when we raise the mercury above the maximum systolic pressure, there is the artery is totally closed, there is no flow, and no sound is heard. If you have a partially closed artery, which is the case between 80 and 120 millimeter mercury in normal individuals, then you will have a turbulent blood flow and you will hear the sound of passage of blood in the brachial artery. I'll stop here and I'll be sending the video and you'll be requested to take notes for the video. Thank you.